Hi everyone, happy Tuesday. Thanks for joining us today. My name is Emily Scahill. I'm the Peer Advocacy Supports and Services Associate at Mental Health America's National Office. Welcome to our webinar on how peer specialists can support harm reduction. Our presenters today are Justin Schumacher and Adrienne Scavera from the Mental Health and Addiction Association of Oregon, one of Oregon's oldest and largest peer-run organizations. Justin is a peer wellness specialist and certified recovery mentor. 2 years ago, he received a liver and kidney transplant due to severe alcohol use. He currently works with MHAAO as a peer support specialist as part of the Navigator program in the Multnomah County Jail. He previously worked at Oregon Health and Science University Hospital as a peer on the addiction medicine team. Adrienne is the Director of Training and Outreach for MHAAO, where she works to support the peer workforce from initial entry and training to systems-level advocacy. Currently, she is a member of the Oregon Health Authority's Peer Delivered Services Core Team and the Unity Center for Behavioral Health Advisory Council, in addition to serving as chair for the State Office of Equity and Inclusion's Training Evaluation and Metrics Program Scoring Committee. She also has the privilege to be on the Traditional Health Worker Commission and University of Washington's Mental Health Technology Transfer Center Advisory Board. So some notes before we get started. At the top of your screen in the gray Start Meeting box, there's a chat bubble, which you can click on to open up a messaging window. So feel free to drop any questions in there, and we can go through them at the end for a Q&A. And we'll also be recording the webinar and sending that out along with the slides after that. So with that, I will turn it over to Justin to get us started.
Hey everyone, it's great to be here. Thank you, Emily, so much. I very much appreciate it. Adrienne is here with me, and we will be supporting each other as we go through this awesome webinar. So, to get started, looking at harm reduction, the Harm Reduction Coalition defines harm reduction as a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. Harm reduction incorporates a spectrum of strategies from safer use to manage use to abstinence to meet drug users where they're at. Addressing conditions of use along with the use itself, because harm reduction demands that interventions and policies designed to serve drug users reflect specific individual community needs. There is no universal definition of or formula for implementing harm reduction. So I think something that's really important with this definition is that within it we see that there is no universal definition of or formula for harm reduction. And that's important because harm reduction is different for everyone. Though we have this definition in front of us, we really are the ones that help our peers determine what harm reduction looks like for them. So just a little bit about MHAAO and our harm reduction programs. As a peer-run organization, our focus is meeting people where they're at. So we have a couple different programs in this. One is the Impact program at OHSU, which I was able to be a part of. So there, I worked as a peer support specialist on the addiction medicine team, and I was able to meet peers that were in the hospital that were there for various reasons, whether it be having a medical problem like an abscess, or in the hospital for withdrawal or maybe an overdose. As a peer on that team, I would meet with people in their hospital rooms and be able to talk to them about what they wanted to talk about. My job was there not to tell people what to do. Oftentimes, as someone that's in the hospital, you're pretty overwhelmed because you have doctors telling you what to do from different teams. You have a social worker that's working with you. You have possibly a counselor. And so being a peer in the program was pretty cool because I got to walk into someone's room and say, hey, I'm here to help, and I'm not here to tell you what to do. We also have our Project Nurture program, which works with pregnant women that are also dealing with addiction and substance use and giving them support through their pregnancy. We also have a doula that works with them, right, Adrienne?
Yes. So we, with the Project Nurture program, we have a peer who is a certified peer support specialist and recovery mentor, in addition to being a certified doula. So that's someone who brought both the life experience and the professional skills related to supporting folks who were pregnant and were also facing challenges associated with addiction. And so that was another example of a harm reduction program that we have here at MHAO. As a peer-run organization, like Justin had said, our focus is really on meeting people where they're at and recognizing that recovery is going to look different for all of us. So we really respect and honor that. I think Justin had made a great point earlier speaking about the fact that there isn't really one set specific definition of harm reduction, but it really is a focus on meeting people where they're at, which is very, very peer, in line with peer values and philosophies. And so those are just a couple of highlighted programs that we have at MHAO. They do a lot of specific work about harm reduction, but we also have a number of other various programs too.
And one other, the program that I'm currently working with is the Jail Navigator program. So currently I'm working with a county jail, and my job is to meet peers that are coming out and get them connected to services. And while I'm with that peer and getting them connected, that is where we're having the harm reduction conversations. So I'm with somebody that is very much in active use or in danger of relapse, and I'm able to talk to them about what their goals are, and those goals aren't necessarily abstinence or stopping use. Their goals are getting housing or getting connected to their disability. Those are things that are the more basic needs that are more important at the time than necessarily just abstinence.
Mm-hmm.
So moving on to some of the harm reduction principles. So we accept, for better or for worse, that illicit and illicit drug use is part of our world and chooses to work to minimize its harmful effects rather than simply ignore or condemn them. We understand drug use, that it is a complex, multifaceted phenomenon that encompasses a continuum of behaviors from severe abuse to total abstinence, and acknowledge that some ways of using drugs are clearly safer than others. Redefines successful intervention, establishes quality of individual and community life and well-being, not necessarily cessation of all drug use as the criteria for successful interventions and policies. Comes from a place of non-judgment. It is also a non-coercive provision of services and resources to people who use drugs and the communities in which they live in order to assist them in reducing attendant harm. Real voice for the user. Ensures that drug users and those with a history of drug use routinely have a real voice in the creation of programs and policies designed to serve them. Gives back power. Affirms drug users themselves as the primary agents of reducing the harms of their drug use, and seeks to empower users to share information and support each other in strategies which meet their actual conditions of use. Recognizes hurdles. Operates from a place of the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequities that affect both people's vulnerability to and capacity for effectively dealing with drug-related harm. Does not sugarcoat reality. Does not attempt to minimize or ignore the real and tragic harm and danger associated with illicit or licit drug use. And I will say that though we continue to hear the word drug, being a peer in the different facets of what we do, you could easily substitute drug for alcohol or any other kind of addiction like gambling or sex addiction. Mm-hmm. So we understand that harm reduction is not just about drug use, even though that's the points that you see in front of you. So where do peers fit in? So peer support is about understanding another's situation empathically through the shared experience of emotional and psychological pain. When people find affiliation with others whom they feel are like them, they feel a connection. This connection or affiliation is a deep, holistic understanding based on mutual experience where people are able to be with each other without the constraints of traditional expert or patient relationships.
So Justin, let's talk for a second about how those harm reduction principles really fit in related to peer support. I mean, many of the principles that you were sharing really lined up quite nicely with the values of peer support, like redefining success. You know, as peer supports, we are not coming in with an agenda. We're not saying this is what an individual needs to do. We are supporting them to make informed decisions for themselves about their lives. You know, coming from a place of non-judgment, that is something that we are always operating from as peers. You know, we are not coming into this work with judgment of others, helping to ensure that there is a voice for the user, a voice for our peers, you know, giving back power. Not only is that something that is trauma-informed, but also in line with our peer support values, as well as not sugarcoating reality, you know, recognizing that there are some really tough challenges in life and connected to youth, and that we can acknowledge and validate those while helping someone to explore the possibilities of what their decisions might be.
Right, and with that, we all have our different experiences, and so our unique experience of what brought us to being a peer support specialist or working in peer support is not going to be the same for someone that we're serving. So we understand that this isn't a one-size-fits-all, and that's where harm reduction comes into play, is that's why we can't define what harm reduction is for someone, because just as peers ourselves, we have our unique experience and what harm reduction worked for us. We have to be open to what is available to someone that we're working with. So moving on to peer support. So one of the first points is respecting where the peer is. When someone's in active use, they expect that the system surrounding them will shame and punish their use. Peers can come from a place of non-bias and without judgment and open the conversation for safer practices. So oftentimes when someone is in active use, they very much think that the world is looking down on them. And that very well might be true. But as peer support, we are the person that says that it's okay, that we're going to give them grace and allow them to be okay with where they're at, so that we can allow them to open up to us about what they want and what they desire. Oftentimes when I've worked with peers, they're afraid to be honest about where they're at because they assume that I'm going to judge them or try to make them conform to what I want them to be. And they have every reason to think that. That is the world that surrounds them, whether they're involved in a treatment program, where they're involved in a judicial program. They have a lot of people giving them constraints, especially even when it comes to their family dynamic. They are having to own up to their own family where, because the family is trying to protect them and they want the best for them, they are often not able to be honest about their own use to the people that they love the most. So that leads to just talking about reality, giving the peer assurance that they do not need to make any promises about staying sober. So currently in the program that I work with, my peers are very apprehensive about being honest about their use because they feel that they will be disqualified from the program because they are not sober. And it's my opportunity to let them know that their use has nothing to do with the amount of help that they're going to get or assistance that they're going to get, that we want to be able to have them be honest with themselves and let us know what they think is best for the type of help that they might want. Next part was just listening, allowing them to be heard without having to defend themselves. Oftentimes, when talking to a peer and talking about substance use, the peer will defend or explain or deny or excuse, and we're the person to say that, hey, like, we're not here to change who you are. We're here to give you support around who you are. And oftentimes I've found that peers don't have that space where they're allowed to talk about themselves, that they are usually in a place where they feel like they have to lie or to not be completely truthful. And even in my own experience as an alcoholic, that's something that I desperately wanted, was that I wanted to be able to be honest with people that I love the most, but instead I spent a lot of my time defending or pushing off really what was going on. So working with these peers and working with the harm reduction lens, we're telling them that I'm here to listen to you and I'm not going to have any kind of judgment. I just want to hear what's going on, which leads us to not taking sides, being the unbiased person that sees the whole situation. As somebody that comes from a place of non-judgment and a place of non-bias, I just want to hear what's going on with them. So I want to be able to know what type of use that they're at. I want to know how much that they're drinking a day. I want to know what their practice is for, say, heroin, if they're shooting heroin or if they're smoking it. I need them to be honest with me so that I can take in all of the information so that I can help them with the decisions that they want to make. The final part that I put here is redirecting the conversation, helping them to keep track with making the best decisions for them and their situation. Oftentimes, I only have a small window to work with a peer, and you can talk to them about a multitude of things, but you want the peer to be leaving the conversation with some idea of harm reduction. That could be something as simply as where to get clean needles. That could be something as simple as understanding that if they're using a needle, the proper way to clean it or to clean their skin before they shoot it. Understanding that the differences between the end game of using a drug through injection versus inhalation. The peer needs to come away from the conversation understanding that there are ways to be safer and there are ways to, reduce the amount of harm that they're doing to themselves with their use.
Absolutely. And I think even if you're tuning into this webinar because harm reduction is completely new to you, you may not be familiar yet, I think these points that Justin has just shared are probably feeling pretty familiar for any of us who does peer support, respecting where that peer is, listening without judgment, not taking sides, not having a bias, helping to support them to stay on track related to the goals that they set for themselves. So I think these are really applicable across peer support and especially relevant when we look at harm reduction.
So let's talk about some harm reduction strategies. So first we're going to talk about managed use. So IV drug use can increase the risk of getting and transmitting HIV, hepatitis, and other bloodborne infections if the needle isn't sterile or if it's being shared with other people. So what we've included is a national map of syringe service programs. So if you click on this map, you can use it to look at what is around in your area, see where you can look at a multitude of different things. So there are syringe service programs that are available in various clinics or pharmacies where you can get clean needles. You can go to a needle exchange where you can dispose of used needles and get new ones. You can look for overdose rescue kits, which would include naloxone, which, as if you don't know, naloxone can be used to reverse an opioid overdose. Also where we can pick up sharps containers so that people have a safe storage for used syringes. Oftentimes, I think that as a society, we think about someone that uses IV drugs, and the first thing we think about is used needles being unsafely disposed of or left out. So this is a conversation that you can have with a peer of just saying, like, where do you put your used needles? And maybe it's as simple as getting them a sharps container, or at least giving them the information where they can get a sharps container. Also, there's risk-reduced counseling. So much like the conversation that we're having about harm reduction, there's information available where you can find and seek out the risk reduction counseling. Also, safer sex supplies. Again, with harm reduction, we're not just talking about just IV use. We're also talking about protection for sex and really looking at different ways like PrEP, for instance, a medicine that you can take for HIV, where, again, we're reducing that harm to the people in our community and just being safer as a whole. Also, wound and abscess care. So there are many programs that do wound care in various cities where they will go and if you are experiencing an abscess or you've recently left the hospital, that you can access that service for free, where they will allow you to get care for that. And then referrals to medical and mental health care, also shelter services, and alcohol and drug treatment. So overall, with this map that you're seeing in this website, you can really find a lot of information for your particular area and what's available to you. So next we're going to talk about MAT, so medication-assisted treatment. So for MAT, we're looking at scientific research in this area demonstrates that when they are used effectively, medications to treat substance use disorder and alcohol use disorder have been shown to be an effective protocol and have provided successful long-term outcomes. And this approach is supported by the FDA and SAMHSA. So when we're looking at medication-assisted treatment, we're looking at methadone, naltrexone, and buprenorphine. So methadone is what is most common. So methadone, if you don't know, is an opioid agonist that does not block other narcotics while preventing withdrawal while taking it. It is taken daily via regulated clinics. Next, we have naltrexone, an opioid antagonist that blocks the effects of other narcotics. It is taken daily as a pill or monthly injection. And I will say that naltrexone can also be used for alcohol as well. And then bup, an opioid agonist and antagonist that blocks other narcotics while reducing withdrawal risk. It is taken daily as a dissolving tablet, cheek film, or a 6-month implant under the skin. So with Suboxone, which are what a lot of people are familiar with, you have bup and naltrexone in the same pill, and this reduces overdoses and also allows for those that have opioid dependence to be able to take care of it without having to use heroin.
All right, so Justin's going to talk a little bit about how to integrate those harm reduction principles that he was just sharing into the peer support relationship and sharing some takeaways around that before we go into a little bit more information about what some of the critics of harm reduction have said, how we might address that criticism, as well as sharing some success stories and statistics around what harm reduction has looked like in practice.
So integrating harm reduction principles into peer support. So work on building a trusting relationship, remove bias and judgment on what your peer decides to do. Look for opportunities to educate about harm reduction, needle exchange, changing use methods, stability on MAT. Ask the peer if they understand harm reduction. Give them stability even in active use. So I think that for me, when we're talking about the peers and understanding harm reduction, one does that peer understand that you're supporting them and that you are finding ways to decrease the risk for harming themselves and those around them? I think that you're looking for a receipt from the peer, that they understand that, one, that you're on their side, and that also that you need them to understand that your goal is to not try to get them to stop using, but to just use in a safer way.
Yeah, Justin, do you have any examples from your work in peer support about where you've really seen some of that harm reduction work in practice?
Yes, I think the one thing that the conversation that I have often is asking someone if they have an alternative method to use. So with someone that is injecting a drug, for instance, if they do not have the ability to access clean needles, asking them how I can help them, how I can find a way, can I deliver them needles? Is there a way that that I can get them to that place, instead of just kind of leaving it to them and hoping for the best? Also, with injection use, asking them if they've considered trying to smoke their drug or inhale it instead of shooting. And the reason why that I tell the peers is because, having worked in a hospital, I've seen the end result of an abscess leading to losing a limb. And I think that those that are in active use don't think about the long-term effects, because they are just trying to get by this day that they're currently in. And never am I coming from a place of trying to scare them, but I think that there's a lack of knowledge about what can eventually happen. And oftentimes the peers come from a place of not understanding what's going on. And in those cases, I think that my goal is to educate them so that they understand that there are alternatives and there are safer ways to use. And that my goal is never to get them to stop. My goal is just to say, like, I accept you. Let's just see how we can help.
Yeah, I really hear in your example, Justin, going back into that principle of not minimizing or ignoring some of those challenging harms and dangers that can come from drug use, and not sugarcoating it, being open, honest, and transparent with those that we support, and doing that in a non-judgmental way, not trying to shame or blame someone or really terrify them, but just, sharing the facts as they may be.
I think, too, when you have someone that has an alcohol use disorder, they come from a place of everyone's telling them to stop drinking immediately. And that might not be actually safe for them. They might not understand that completely drinking alcohol all at once could possibly put them in a place where they could have a seizure because of withdrawal. That is not something that's common knowledge, unfortunately, for people that are in alcohol use disorder. And so I'm going to be the person that says, maybe not stop drinking. Maybe we can drink less. And peers are not used to hearing that. They're very much used to hearing people just tell them to stop. Mm-hmm. And when they realize that you're there for support and that you're telling them how we can help them instead of just quitting everything, mm-hmm. they understand that you have their back.
And the incredible impact that can have on the trusting relationship that we can build with someone when they recognize that we're there to support them and meet them where they are at, and not come in and say, you must stop all use immediately. That may feel like something that is completely not feasible. That may feel like something that's not doable at all for a person. So if we can come in and say, hey, I'm going to work with you and I support you as you are, and hey, do you know about this clean needle exchange, 2 blocks west? then they might have a little bit safer experience that is less likely to cause physical harm and the emotional stress that can come with that as well. And then we can work from there because we're meeting people where they're at, and I think that's really so, so critical here.
Absolutely. I think, too, that when we're talking about peer support and in the harm reduction model, again, those peers are not used to hearing someone support their use. And it sounds, I think they sometimes almost don't trust it because why would you be telling me to continue to use? And really what we're really getting at is we're not trying to change you. We're just trying to help you. So when we talk about harm reduction, there is some obvious criticism out there, and I wanted to take some time to address that. And I think that we can really get on the same page when it comes to helping our peers and helping reduce the harm that they do to themselves or those around them. But we really get a lot of pushback from those that don't understand, one, and that, two, don't believe that we are actually helping people by using a harm reduction lens. So the first thing I want to talk about is bootstrap mentality. And what I mean by bootstrap mentality is pretty simply what it says, bootstrap. We all know that person that says, well, Johnny was able to quit because he pulled himself up by his bootstraps and he was able to just stop, and now he's living this amazing life, and I want this person to be like that. You're working with a peer right now, why don't you just tell them that it's just better if they quit? And we all know it's not that easy. That's not realistic, and those one-off people, they exist in the world, but that is not the norm. I mean, I would say that if it had been easy for me to just pull myself up by my bootstraps, I definitely would have not landed in the hospital. I would have definitely been able just to quit because I wanted to. And so, again, with the people that critique us and criticize the fact that we are trying to help people, they need to understand that it's just not that easy. Oftentimes, with that, we see those people that are saying the bootstrap mentality, that they have inexperience with addiction or mental illness. They very much have not had to experience and struggle with their own mental illness or addiction because they, unfortunately, or fortunately, don't suffer from it. And they don't have the same lens to understand those around them that do have to suffer or deal with addiction and mental illness. So I think that we are given an opportunity to educate those, and we are working from the lens of addiction as a disease, and we need to take that time and opportunity to tell those people that it's not that easy. You can't tell someone just to get over diabetes. No one would do that. So again, educating those around us that would be the ones to criticize the harm reduction model. Oftentimes we'll hear that harm reduction gives permission for use. And what I would say to that is that we are giving permission for use because we're telling someone that it's okay. But we're also providing them with a surrounding of education and support to help them. We're not telling someone just to go use and that's the end of it, that the conversation's over. Our conversation is really about you can use and I'm going to provide you support in what you want to do around it. And if it is something as simple as maybe using less or maybe a different method, that's okay too. But never we're just saying like this person should go use and then that's the end of the conversation. Safe injection sites increase use. So I think this is a really common thing that we hear in that if there were to be a safe injection site put in our, in the middle of our city that all of a sudden that people would flock from all over, and everyone would now start their IV drug use when they were apprehensive about it before. And the way to compare safe injection site use that increases use is that if I were living in a large city and I was given the ability to walk downtown barefoot, and I happened to be able to step on a needle and possibly get hepatitis C, I would much rather there be a safe injection site where someone can use safely than to deny them that ability and increase the chance of harming myself because there was no place for them to put a needle. So again, in the safe injection sites, we really are looking at those as a way to say, like, we understand that use exists. We're not saying we're not in denial, and we're giving them a place to do it instead of just out in the open where people can possibly do harm to others, and not intentionally, just by the fact that people are going to use, and sometimes there's not places to put needles. And so, again, this doesn't have anything to do with increasing use. It really just has to do with supporting people that are already using. For MAT, we will hear that it switches one drug for another. And so that somebody that uses methadone for their opioid dependence versus heroin is that we're just getting them hooked on another drug. And again, what I would say to that is that with just using heroin as an example, the user doesn't necessarily know what's cut with their heroin. They don't know the purity of it. And they are taking a chance every single time that they use, that they could be getting fentanyl, that they could be subject to an overdose, that they could be possibly even using what they think is a clean and safe needle, but still risking getting an abscess and possibly even losing a limb. So when I compare that to going to a place and getting methadone, which is safe, which is protected, again, we would much rather someone use methadone that is pure in content, that they know what it's getting, that the amount is measured, versus someone risking using heroin on the street and possibly doing damage to themselves that is just not needed. And then finally with, sometimes critics will say that we're praising addiction and addicts for being responsible instead of getting help. And to that, I would say that you can be actively looking for help while you are active in drug use. They're not mutually exclusive. And so, yes, we are telling people that they are doing a good job of being safe in their use, and we're supporting them getting help in their use. We don't have to just decide that you have to stop immediately, and that's the only way that you can get help. That's nearly impossible. We have to be there to support them every step of the way. There's a comedian that tells a joke about addiction, and he says that addiction is the only disease that gets you yelled at. So we never would yell at someone for having heart disease. We would never yell at someone for having diabetes. But oftentimes those that suffer from addiction as a disease, that we are quick to judge and quick to blame instead of accepting the fact that they do suffer from a disease just like someone else that suffers from Parkinson's. So I think oftentimes with critics, we need to remind them that, hey, these people have a disease and we have to be there to support them. So just some follow-up points to that as we switch slides here. Cool. So harm reduction is not anti-abstinence, nor does it promote use. harm reduction can be a very effective part of a person's recovery process. Harm reduction saves lives. Not only does it promote health and safety, but it can help keep someone alive long enough to make decisions about their use and recovery, and to seek out support if desired.
I'd also like to add one thing, which is harm reduction not only promotes health and safety for the individual who may be using, but it promotes public health and safety as well. Like in that example that had been shared, if I am in a public park and there are kids running around and there are uncapped needles on the ground, that could potentially have a very significant impact on someone that is running around playing in the park and has a needle go through the skin of their feet, or they fall or something like that. So this is really a public health issue as well, and harm reduction supports that level as well as individually. So we wanted to share a little bit about the success that Portugal has seen related to drug decriminalization. This is something that you may be familiar with. It's actually relatively recent, within the past decade. So in 2001, Portugal launched a drug decriminalization program in response to a public health crisis that they were experiencing related to addiction. They had one of the highest rates of use and overdoses within Europe. In 2001, they made the decision as a country to become the first in the world to decriminalize consumption of all drugs. Now, drug use still has administrative fines associated with it, but they have removed the criminalization of drug use. And as you might imagine, there are a number of statistics that have been collected in Portugal after the decriminalization that occurred. So they saw that overdose deaths decreased by over 80%. The prevalence rate of people who use drugs that account for new HIV/AIDS diagnoses fell from 52% prior to decriminalization to 6%. Incarceration for drug offenses decreased by over 40%. And while all of those above we saw decreases, the numbers of folks in Portugal who were voluntarily accessing treatment significantly increased once it no longer became a criminal offense to be using drugs. And if you're interested in looking more in this, there's a lot of really interesting information that's available online. We've got one example from drugpolicy.org on our slide, but there's a lot of really great information out there that can show examples of what a decriminalization approach can look like, which can be one component of a harm reduction approach.
Absolutely. And also, too, again, when we're talking with people that criticize harm reduction, Portugal is a great example that can be used for someone to understand that this is a country that took a different frame point and made it work. But I wanted to share with y'all the International Task Force on Strategic Drug Policy, their statement on harm reduction. And so this is part of that counterpoint, the thing that we're fighting against. So they say, we oppose so-called harm reduction strategies as endpoints that promote the false notion that there are safe or responsible ways to use drugs. That is, strategies in which the primary goal to enable drug users to maintain addictive, destructive, and compulsive behavior by misleading users about some drug risks while ignoring others. These strategies give the message that society has given up on the addict, condones their drug use, and condemns them to a life of drug dependence. So when I read this as a shame statement. So when you look at, again, where others are coming from that don't understand harm reduction, you really see the viewpoint that, like it says, it condones drug use and condemns them to a life of drug dependence. This is a counterpoint to how we understand addiction as a disease. coming from a lens of harm reduction, we understand that that there's no condemning anyone, that people are going to always suffer from this addiction, and that we can be the ones that support them. Also, with this statement and my opinion, that's the shame statement. Oftentimes, when we have someone that's in active use, shaming this person, making them feel bad about their use, tends to lead to more use and to less information that's shared and to less openness of how you can help this person. So this is just there for you to understand that this is the counterpoint to what we're talking about. And with that being said, our next slide, this is the Global Commission on Drug Policy's core principle. In the criminalization, marginalization, and stigmatization of people who use drugs but who do no harm to others, challenge rather than reinforce common misconceptions about drug markets, drug use, and drug dependence.
It's interesting to see the contrast between those two statements and those two philosophies, both from global bodies that are connected to drug policy. And one approaches with the viewpoint that is more based in shame or not recognizing that there are safer and more responsible ways to use. I would say, is it safer to use a needle that has been used by others and used multiple times? Or is it safer to use a needle that is new and cleaning and preparing the skin prior to that? I imagine that anyone, regardless of personal perspective or viewpoint, would agree that that would be a safer approach more likely to not cause harm to that individual or others who may be sharing that same needle. And then we have the Global Commission on Drug Policy principle here that recognizes the stigmatization that occurs, the marginalization, the criminalization that is true. So two very different viewpoints. So some places are at different places with respect to their understanding and support of harm reduction. So we're just trying to share that there are different bodies that have different perspectives on it.
So the next thing that we're going to talk about is Insite. So it's a safe injection site in Vancouver, BC. It is North America's first legal supervised consumption site. It opened in 2003 and is in Vancouver's downtown area, where there's a number of long-term injection drug users. The facility operates under a Health Canada exemption from prosecution under federal drug laws. Insite operates on a harm reduction model, which means it strives to decrease the adverse health, social, and economic consequences of drug use without requiring abstinence from drug use. So again, when we're talking about the harm reduction model, I think that we're really focusing on the proof behind the pudding. We need for people to understand that there are countries, sites where this is working, and just providing you the context for to explain to your peers and to those around them that we can help even though someone's in active use. So here is some more information about Insite. So Insite is a supervised drug consumption site accessible to street drug users. Insite is injection booths where clients inject pre-obtained illicit drugs under the supervision of nurses and healthcare staff. Clean injection equipment such as syringes, cookers, filters, water, and tourniquets are supplied. If an overdose occurs, the team, led by a nurse, are available to intervene immediately. Nurses also provide other healthcare services like wound care and immunizations. So with this site, yes, they do not provide the drugs for you, but at the same time, they are there to support you in your use. And when it says, like, if an overdose occurs, they are there to respond. They are there 24/7, and the site is, again, it's there to give somebody a place to do this, as opposed to what was before in this area of the city was a heavily, used area where people were injecting without safety, and it was a part of the city that people had kind of condemned. So Vancouver took this, this area and really turned it around by just providing this site for people that are there. At Insite, clients develop relationships and build trust with healthcare workers, which makes clients more likely to pursue withdrawal management, addiction counseling, and other addiction recovery services. When users are ready to access withdrawal management, they can be immediately accommodated at on-site, where people can detox in 12 rooms with private bathrooms. Mental health workers, counselors, nurses, and doctors work together to help people stabilize and plan their next steps. Once stabilized, clients can move to the third floor transitional recovery housing for further recovery and connection to community support, treatment programs, and housing. So here are some amazing statistics from Insite. So there have been 3.6 million visits to inject illicit drugs under supervision since 2003. So these numbers are from 2003 to 2018. So 3.6 million visits. There have been 48,000 clinical treatment visits and over 6,000 overdose interventions, and there have been 0 deaths. So 3.6 million injections and 0 deaths. This is how harm reduction works. Giving a place of support for people that we can intervene in an overdose, we can provide material for that person to detox, and we are there to support them. And I think that's why it speaks to the 0 deaths. So looking at 2017, we have 175,000 visits with over 5,000 individuals, average of 356 injection room visits per day, 1,900 overdose interventions, and 3,402 clinical treatment interventions such as wound care, pregnancy tests, and pregnancy tests. I'll leave it at that. So for 2018, we see actually an increase in visits. So over 15,000 more visits by roughly the same amount of individuals, about 100 more individuals, with 337 injection room visits per day, so a little bit lower than the year before. But here's the important number. With 15,000 more visits the next year, we have 500 less overdose interventions. So we're seeing roughly the same amount of people and an increase, people that are gaining knowledge that this is a place that they can go, but because of the knowledge and the support that they are given there, less overdoses. Also, we're looking at a little bit more, 300 more clinical treatment interventions, such as wound care and pregnancy tests. Again, giving that support, wrapping around those people and saying, like, we are here to support you. How can we help? So something I wanted to summarize with is how peer support and harm reduction is aligned. So we open up a dialogue about substance abuse. We have the ability to be with a peer where they're at, and we have the ability to talk to them honestly and openly about what they think about their use, where they want to go with it, whether it be stay the same or increase use or decrease. We are there to give them that support, and we are there to have an honest conversation. We give the peer the opportunity to be heard without having to fear being judged. Again, having an honest conversation. Oftentimes, our peers are constantly being judged, constantly being told what to do, and constantly being fearful that they're not allowed to be honest about where they're at with things. I personally encourage peers to tell me about their use and what they want to do with it, and I support them by saying up front that I'm not coming from a place of judgment. I just need you to tell me where you're at with things, and then we can go from there. We promote strategies that are proven to reduce health complications and strengthen community relationships. We allow the peer to be in control instead of being told how to live. And we educate the peer on alternative options and give opportunity for the peer to use their own judgment based on what they have learned. And this goes back to getting that receipt from the peer of understanding. They're walking away after we've had a harm reduction conversation. We need to make sure that they understand that they feel supported and that they understand that there are alternatives and there are ways to give them leverage on the way that they want to continue their use or stop or slow down their use.
Yeah, those are great points. I think throughout the approach of harm reduction, it really aligns so well with peer support, because you've probably heard us say this 10 times over this webinar, but we're here to meet people where they're at, without judgment, with openness, with transparency, and with a commitment to supporting people in the way that works best for them. And harm reduction really promotes that peer support philosophy in that way. So harm reduction can really play an important part of the peer support services that we provide to those in our communities. So with that, it looks like we've got a good amount of time for a Q&A. Emily, do we have any questions that are out there for us?
We don't have any right now, but like I mentioned earlier, for those participating, if you want to hit the chat bubble up in that gray box and put your questions in there, happy to bring those into this conversation. So we can give it a few minutes to see if people have things they want to ask and go from there.
Okay, thank you, Emily. I just saw a chat bubble come up, so maybe that was a question.
Yeah, so we have a few about if the presentation will be available for download. Yes, if you joined us late, I will be sending out a PDF of the slides as well as the full recording of this webinar afterwards.
Thank you so much. That's great.
Yeah.
And I just want to say that Justin and I welcome any questions without judgment. So please feel free, if you're thinking about entering a question, please feel free to do that.
We are going to practice harm reduction with the questions.
All right, we got one. What are good resources for information about risks associated with use to enable peer supporters to inform without judgment?
So let me make sure I'm getting the question right. You are looking for resources related to statistics or facts about use to provide to someone that you're providing peer support to?
I believe so, yeah.
Yes. So there are a number, there's actually many, many resources available online. If you're interested in looking for a specific substance, then you can search for that. You know, I would just Google that particular substance and search for it that way. There also are some websites that are out there that have a decent amount of general information on them, like the Substance Abuse and Mental Health Services Administration or SAMHSA, the Harm Reduction Coalition website. There is a drug policy website that has some information on it. There are a variety of websites that are out there, and sometimes also in your local communities, there are sometimes clinics will share information or have little quick pamphlets that you can just carry around with you, and when you're meeting with someone, you can share that. Or if a person prefers to receive information online via text or email, then you can use some of those online resources.
And I would say that statistics are important, and they can prove a point, but they can also disprove a point. And so when you're talking about harm reduction and risks with a peer, it's important to really understand exactly what what they would be wanting from a statistic, it's really important, I think, to just talk about what next step is for them, and then talk about the many possibilities of what their use could do going forward, or if they're reduced use, what is in the realm of possibility for them.
Thank you. If there are any other questions?
Just got one more.
Okay.
So someone said, it is strange to me how drug use, including marijuana, is becoming widespread and accepted, and those that don't take part are subject to secondhand smoke in homes or cars or stores. It's hard to get a grip on drug use being more encouraged in America, and wanted to know your thoughts on that.
So first, I would say that from my perspective, I don't believe that drug use is being more encouraged, with the exception that, yes, in many states have taken the stance that marijuana is now legal for consumption. Federally, it is still illegal to consume marijuana, but the harm reduction approach isn't to encourage drug use, it's to encourage the safer and more responsible use of a drug that a person would already be using. So the intent of harm reduction isn't to draw folks into use to start using, but to support those who may be in active addiction to make safer choices around their use.
I think that when we look at alcohol, because alcohol is a drug, that we're encouraged all of the time to drink. It is all around us all the time. And for someone that has alcohol use disorder, it is very, very hard to ignore all of the encouragement. And so, again, when we have someone that is going to be, for instance, drinking, from a harm reduction model, they need to understand that it goes beyond just like you could get a DUI. There's other things that can happen too, and we have to be there to support and say, like, I'm not encouraging anything. What I'm saying is that you're drinking. Here are things that could happen. Here are ways that I can support you, and what do you want to do? What do you want to do? Because ultimately it's about the peer and what they want to do with themselves. And so encourage is kind of a difficult word, because we are here to simply say, I accept you for where you're at with your life, with your use, and what are your goals around that, and what can we do to help?
Great. And then someone else asked, where is the Global Commission policy statement published?
So that is available as a PDF online, and maybe I could share that as a resource with Emily. Is it possible to share that with this group as well?
Yes, absolutely. I can send that out.
Great. Thank you. Yeah, I'm just going to make a quick note to myself to send that. It is a pretty lengthy document. I just pulled from the first part of the document, but it is a pretty good read.
Great. We just got a few more questions.
Okay.
So here's one. I've asked a peer who began using alcohol again how they felt about it, and they said they liked it. What would you say next?
We're thinking about that one.
I would say great. And then what's the reasoning behind them using alcohol again? Do they feel like this is something that can be positive in their life, something that might have consequences? And I would try to gain a little bit more information around what that use is doing for them, I think that we know that as addiction is a disease, that we have a desire to fill in when we're bored, when we're lonely, when we have a lack of connection around us, when we feel shame on ourselves, and what are we using the alcohol for? And then what part can we support in them that maybe that they're missing out on?
Great, and then we've got one last one, it seems, not quite a question, but something I want to throw out there, and other people are welcome to comment on this comment as well. So someone said, I am a member of NAMI and facilitate family-to-family classes. My struggle is, although drug use and the opioid abuse has become a major focus, it is overshadowing mental illness. Not all have drug addiction associated with their illness, and funding should be considered for all illness. Drug abuse did not just begin happening.
I agree that I think there should be parity with respect to mental health and addiction or substance use disorder. I think specifically today what we were looking at was addiction or substance use as that relates to a harm reduction approach, but I absolutely hear your point and agree that there should be parity for both of those experiences.
All right, well, it looks like people are starting to leave the webinar, and I don't see anyone typing or any other questions. So we can end here for today if that sounds good to everyone. And I am happy to send out any resources that you guys have, Justin and Adrian.
Okay.
And like I mentioned, I will send out the slides, the recording of this, and everyone's contact info is on the screen right now. So people are welcome to reach out to Justin and Adrian directly.
Awesome.
Yes. Thank you all so much for the opportunity to come and share some information about harm reduction. Like Emily had said, our information, our emails are up on the slide, and you'll be receiving the slides as well. So please reach out if you want to continue the conversation or have any questions come up. I know sometimes it can take a minute to process getting a lot of information in a pretty quick way.
And I'm always available to answer any questions. This is something that I use with my daily peer support, and I'm more than willing to reach back out and talk some more about it.
Great. Thanks so much, everyone. Have a great afternoon.
Thank you all so much. Goodbye.
Bye.